And hypertension is also a huge element. It doesn't really affect men or women differently when it affects them, but when it does affect you, you have 3 times likelihood of having heart disease. And we think that if we eliminate pre-high blood pressure, meaning those numbers between 120 and 140, because really, you hear your doctor say, well, you're below 140, you're okay. Well, by standard definition, that really now is considered pre-high blood pressure. Really a normal blood pressure below 120. If we got rid of those folks between 120 and 140, we get almost half a reduction, or 50% reduction in recurrent heart attack. And interestingly, a third, this is a good statistic as well, a third of Americans, or 1 in 3, if you look around, there's 3 people at most tables, so 1 of you will have high blood pressure, and out of those a third of you don't know you have it, and are not being treated, not being supervised with it. To get rid of it, some of it's easy. Salt reduction, exercise, keep your weight down. Reduce your caffeine and alcohol intake to more moderate levels. But even with some of that, you still are going to have folks who have bad genes that wind up requiring medications. And the average requirements for medications are 3 medications to get this under control. So it's something that you want to avoid if you can. In societies that have sodium consumption of less than 2 grams per day, they don't have hypertension in their society or high blood pressure in their society, period. From age 50 to age 100, they just don't have it. And so, again, we're doing a lot of this stuff to ourselves. The smoking, again, increases your risk by 10-fold, probably the most deadly, next to diabetes, of the risks. And then back to some women-specific stuff here, menopause and estrogen issues. This has been a big issue. There's been a lot of back and forth about this over the last decade. For a long while, estrogen replacement in the setting of menopause was considered standard care because it actually made the lipid panel or the cholesterol panel look better. Your LDL would come down, your HDL would go up, it obviously would relieve the menopausal symptoms of the hot flashes and vaginal dryness and those kinds of issues. And so they thought it was going to be a win-win. Your bones do better because with estrogen you lay more calcium down in your bones when you go into menopause. That's why women after menopause get more brittle bones. The estrogen can't help lay the calcium down. But then they really started looking at this critically, and there were 3 big studies: the Nurses' Health Study, something called the HERS trial, and the Women's Health Initiative trial, the WHI trial. And all 3 of them showed increased heart attack and death rate in women who were on estrogen replacement compared to those that weren't. And this raised up a huge red flag, as you might imagine. Our standard of care was being fully questioned, saying, wow, we're actually killing women by putting them on estrogen. So that really got people worked up, and they really started to look at these numbers a lot more in detail. And what they found was there was a big dichotomy. Women that were, I think I've got some slides on this. No, it goes elsewhere. Women that were started on estrogen and left on estrogen for years and years were really the ones that ran into trouble. It was women that were 15 to 20 years after menopause that were still on estrogen that had the problem. The women that were put on estrogen for relief of symptoms for 5 years, 7 years, even up to 10 years, and then taken off judiciously and gradually, those folks didn't have any negative outcomes. Unless you were at risk of stroke. That's the one area that they did still find, even if you were only on it for 5 or 10 years, if you had any risk of stroke, you had a much higher chance of having a stroke if you were on hormone replacement therapy. And so this has really gotten folks into, rattling the cages of their primary doctors and saying, okay, let's think about this. Don't just put someone on estrogen therapy and leave them on it for 20 years. You're going to really increase the risk of dying of a heart attack. Some of the other interesting things about estrogen in the heart, that there's a whole load of estrogen receptors in the heart muscle tissue and in the arteries around the heart. And one of the things that estrogen helps the heart to make is something called nitric oxide. You've probably heard of nitric oxide, where you breathe at the dentist's office to or laughing gas. Well, nitric oxide is a different form of that allows the arteries to relax. It allows the heart to become less inflamed and less stiff. And so after you get withdrawn from estrogen through menopause, either surgical or natural menopause, all that good nitric oxide goes away. And your heart becomes stiffer, your arteries become stiffer, and it's a lot easier for you to allow fatty plaque to be developed into the artery wall. There's also, interestingly, many more adrenaline receptors in the heart of women than in the hearts of men. And that adrenaline receptor, that adrenaline chemical, is made by the adrenal glands, that fight or flight hormone. And so that's why we think that women in their kind of perimenopausal period have a lot more what we call palpitations or skipped heartbeats or fast heartbeats, directly related to this higher level of adrenaline receptors and estrogen receptors in the heart. So this is, this is really basic science stuff that we're really starting to figure out the physiologic differences between these two sexes in their hearts. And then we kind of go on here. I touched a little bit on that business about the gingivitis and the inflammation, just to bring that up again. And those that kind of continue to keep their gums in good health through flossing and brushing whatever 2 or 3 times a day have a substantially reduced heart attack risk, again, because of that decreased inflammation. But it's not just gingivitis, again, as I alluded to, those that have rheumatoid arthritis, those that have lupus, those that have other inflammatory autoimmune diseases. If those autoimmune diseases are kept under control, they have much less event rates than those that aren't and are allowed to be chronically inflamed. So then here we go again for that early menopause that we were talking about. So a 2-fold increase in heart attack or stroke if you have menopause before the age of 46, either regular menopause or if you had both of your ovaries taken out. Basically 14% in normal and folks that don't go through early menopause compared to 28%. And all the events occurred after the age of 55 in this one cohort of patients. I think we talked on mainly most of this stuff with the estrogen replacement already. No apparent harm or benefit in coronary disease in young women close to the menopausal age. And we really need to screen for the risk of stroke before starting hormone therapy. And so those folks with problems of high blood pressure, high cholesterol, diabetes, smokers, probably ought not be on hormone replacement therapy unless those other risk factors are attenuated first. And this is just the conclusion from all that. Basically, screen for high risk and get people off as soon as they can. So the other very female-specific thing that happens to women and not to men, obviously, is pregnancy. And how does that impact our heart? Well, interestingly, about 4% of people who have pregnancies will develop preeclampsia. You probably know what that is. It's kind of this pre-high blood pressure that can ultimately develop into eclampsia, which is a much more critical thing. And we kind of poo-poo it, oh, they developed preeclampsia, they got a little bed rest, they did better after delivery, no big deal, but that's really not the case. Preeclampsia is associated with developing the metabolic syndrome or that prediabetes syndrome. It's associated with developing a larger waist circumference, which we know is also an independent risk factor later in life. And we know that the cardiac risks are present within 10 years of the index pregnancy. So if you had your baby at 30, the risk of this started occurring at the age of 40. So there's an increased risk of stroke if you've developed preeclampsia, almost a 20% increased risk. There's an increased risk of future hypertension. Interestingly, look at that relative risk means that's like 100%, so it's like 370% chance of having high blood pressure if you had preeclampsia during pregnancy. And then fatal and non-fatal heart attacks also increases by almost 216%. So kind of in summary for those issues, the OBGYNs really need to get involved in recognizing folks when they have preeclampsia to really jump on those risk factors quickly once they're recognized after delivery. To not let young women dwindle along with a borderline cholesterol, to really jump on that, to not let them kind of percolate along with pre-hypertension or frank hypertension and say, well, you're a little too young to be managed with medications. It doesn't have to be medications, but they have to be managed. You got to get that systolic pressure down close to 120, especially if you're in your 30s and 40s. You should be able to do that without problem. If you can't, you need medication. And so getting the OBGYNs involved in some of this stuff is really going to be critical because many times that's the only point of care of interaction for females in that age group. They don't go to a GP or an internist or certainly to a cardiologist. So it's really at that very basic grassroots level that a lot of this awareness, a lot of this intervention needs to happen. And then back to the last business that we had talked about a little bit earlier about women less likely to seek care. This first statistic is telling only 1/3 of women who receive a prescription for either a blood pressure or cholesterol medicine will fill it. and only a third that fill it will refill it. That's getting down to pretty darn low numbers. It's 1/9 of people will be on their medication chronically. You know, we see people in the office every day. Hey, you taking your medication? Yeah, I'm taking my medications. If we really go and do pill counts on those folks, only 1/9 of people will be doing it every single time. Women present later after symptom onset, as we talked about. They present to the emergency room much later. We know that we have a saying in cardiology, time is muscle. Time is heart muscle. The longer you wait with a heart attack, the more damage gets done. And we have a golden hour. We think we've got about 60 minutes from the onset of a heart attack until permanent damage starts to set in. Unfortunately, women have almost a 50% reduction in time presentation to the emergency room. They're recognized later by the emergency room physicians as having a heart attack, and they're treated less aggressively. I'll go over some of the slides. They're less likely to go to the heart cath lab to get these arteries open, and they're much higher risk of having bleeding problems and other issues as complications of the procedure of the heart catheterization. Here, part of it is this. Part of this is women's knowledge. Again, we've known now since 2000 that this is the leading killer. But if you ask women what the leading killer is in 2003, 40% will still say that it's cancer, and only 20% think that it's their heart. So the presentation, just so that we can all be on the same page as far as what does coronary disease look like. And classically in men, chest pressure, chest pain, but only about 25 to 30% of women present with that classic chest pain or pressure. More likely than not, it's shortness of breath, it's fatigue, it's sometimes just nausea, feeling a little acid and heartburn, or it's just abrupt sweatiness, what we call diaphoresis, where people just look clammy and sweaty for no good reason. Another difficulty in recognizing it, because if you're not coming in with the kind of quote-unquote textbook definition, it's a little bit harder. And so here's what these arteries look like again. So again, here's a good healthy artery. Here's one now that's not 100% blocked off like that other one, but it comes down here and you can see that little tiny thread that's connecting to the rest of this main artery. So that's about a 95% blockage there, and that needs to be opened up. And then after a series of interventions that we do of putting wires through there and these little metal coils, this is what it's supposed to look like in that same region. We've been talking about these stents, so I'll just show you a couple of pictures of the stents themselves. So again, this is the artery cut away. This is the arteries kind of sitting on top of the heart muscle. We slide backwards up through this aorta here with our catheters, put them into the artery, float them down where the blockage is, blow the balloon up under high pressure. That deploys this flat stent into a deployed stent configuration, and the stent is like a little metal meshwork. I'll show you a picture of one in a moment. And then we deflate the balloon and take the balloon out, and the stent lives in the artery forever. Over time, cells go around this area and start to basically put new skin cells on the inside of that stent, so you start to recognize it as your own body tissue after a period of 6 to 12 months. And here's what these stents look like. That's obviously somebody's finger, and that gives you a sense of how tiny these are. These are anywhere from 5 millimeters in length to 30 millimeters in length, and anywhere from 2.5 millimeters in diameter up to biggest is about 4.5 or 5 millimeters in diameter. And here I've been talking about stents. We've also, obviously, people who've had bypass surgery. The bypass surgery, excuse me, is when there's too much blockage to treat with a stent, either because the location is not amenable to stenting or there's just so much disease that you need to do a bypass. And so here, these little spaghetti strings here, these red ones, they're the bypass grafts. When you say people have had bypass, they do either take vein out of the leg and use that, or there's some arteries in the chest wall that they use. They connect them to the aorta and then swing them down beyond where the blockage is and sew them into the artery so that blood can be literally bypassed around the blockage. And so the presentation of women with these heart attacks and blocked arteries, frequently they're older. Frequently they have many more other risk factors than men do when they present, meaning that they have more high blood pressure, more high cholesterol, more diabetes. This Killip class is just a marker of how sick somebody is when they present. So their Killip class is higher. They are